And can you guys hear me okay?
Yes, we can.
Perfect. So I wanted to talk today kind of some cases of pulmonary hypertension and how there's many different flavors of pulmonary hypertension, and usually with their background history and some of the demographics that they make up and some really pertinent medical history, you can usually get an idea of what type they have even just based on that, and it gives you some guidance and know how help guide your therapy. So next slide. Just a disclosure, I'm a speaker for Bayer. The next slide. So if you look at prevalent types of PH, when you look at the WHO Group 1 PH, and that's the idiopathic, this is truly the zebra disease of pulmonary hypertension. The prevalence of PAH, WHO Group 1, is approximately 15 people per million. So very, very, very rare. And if you look at the US population, a little bit older, 319 million, the estimated number of cases of PH in the US is about 4,800. So it's a very, very much an orphan disease, okay? Next slide. However, group 1 is very rare, but pulmonary hypertension, which is the other groups, is very much the horse diagnosis, very, very common. Next slide. Here's a study done in an Australian community of 165,000 people. It was a single echo lab, and they saw all comers of PH noted on the echocardiogram. And what they found was the majority of people that had pulmonary hypertension did not have pulmonary arterial hypertension. In fact, most of them was group 2 pulmonary hypertension, which is left-sided heart disease. So 68%, 2/3 of the patient population, when it was pulmonary hypertension, it was due to left-sided heart disease. And unfortunately, we don't have specific meds to target those patients. Typically, the treatment of that is blood pressure control and diuretics. Agents such as sildenafil and ambrisentan, which is also known as Letairis, some other PH-specific drugs, those are for the group 1, the very rare diagnosis, and those are a very small population. If you look at this slide, the PAH group was only 2.7%, so once again, very, very small proportion. Lung disease disorders were another 10%, and OSA. CTEPH, which is chronic thromboembolic pulmonary hypertension, made up only about 0.5%. And the unknown, probably more related to lung disease, but they're kind of the unknown. So my always rule of thumb is about all PH that comes in West Virginia, about 60% of it's left-sided heart disease, and another 25%, 20 to 25% or so is from lung disease. A lot of emphysema in the community, a lot of COPD. So you see a higher number of lung disease in our population based on the smoking epidemic we have here in the state, and also based on the fact that we have a very bad obesity epidemic as well. Next slide. So pulmonary venous hypertension, this is going to be a viewpoint from our pulmonary hypertension clinic, how you can see a great breadth of different type of patients. And I'm going to contrast with the next slide. We have, next slide. We have 2 patients. We have Jane, who's a 32-year-old female. She's had dyspnea for about 3 years. It's been progressive and has been treated for asthma and depression, but really hasn't gotten better. Echo was eventually done that showed normal LV function, right atrial enlargement, right ventricular enlargement, and an estimated RVSP of 80. In contrast, Sarah is a 76-year-old with hypertension, diabetes, and obesity. She as well had experienced progressive dyspnea for 3 years, but on her echo, she has concentric left ventricular hypertrophy, normal LV function, left atrial enlargement, right atrial enlargement, right ventricular enlargement, and an estimated RVSP of approximately 80. So although both patients have an estimated RVSP of 80, consistent with severe pulmonary hypertension, their pathophysiology is much different. Next slide. And kind of distinguish between PAH from HFpEF. This is a database population of 522 patients with PAH, and then another population of 100 people with PH-HFpEF, and that are people with normal EFs but they have a high wedge LVDP, and their PVR is elevated, and their transpulmonary gradient is elevated as well. So they have HFpEF, but also they have pulmonary hypertension associated with their heart failure preserved EF. And then one last population they had was 45 patients with HFpEF, which basically has an elevated wedge LVDP, but their PVR is low. So the pH is not that severe. And then what they did with those three different populations, they compared the clinical history, echo, and hemodynamic parameters. Next slide. And what you see in the slide, in the PAH population, they tend to be younger, so 48 years old, where the HFpEFers tend to be older. The PAH patients and the PH HFpEFers tend to be more female, where if they just had regular HFpEF, they tend to be less, more close to 50-50 male to female. If you look at functional class, they both are very, dyspneic. However, the hypertension group was more predominant in the HFpEF group, so PH HFpEF and regular HFpEF. Those patients tend to have more diabetes, they tend to have more obesity, and they tend to have more coronary artery disease. So when you have a patient with obesity, diabetes, coronary disease, they're more likely going to have HFpEF physiology. Where if it's a younger female with no history of hypertension or diabetes and not obese, then you think of more PAH. And that's just from the clear clinical characteristics. Next slide. If you look at their echo characteristics, so just all those three different populations, we then looked at what's different on the echo. The big things that kind of stick out are kind of the HFpEFers have more IV septal thickness, so more hypertrophy. The big thing you'll see too is the prevalence of left atrial enlargement, LAE, more prominent in the HFpEF, PH HFpEF, because remember, those disease states is left-sided heart disease. So as the pressure is built up on the left, they push on through to the right side. The PAH patients tend to have right atrial enlargement, the most common thing, and they tend to have more right ventricular hypertrophy. So when the predominant physiology is in the right side of the heart, that's where all the abnormalities are in PAH. Where in contrast to HFpEF and PH HFpEF, a lot of their pathophysiology is on the left side. So you see a lot of left-sided abnormalities on their echo. Next slide. Another thing is looking at their clinical features. Patients that are PAH tend to be younger, as we talked about before. And this is kind of a nice summary slide. The comorbidities are more frequent in the PH HFpEFers. Right atrial enlargement, more frequent in PAH. Left atrial enlargement, very frequent in the HFpEFers and PH HFpEFers. And clinically, you don't need to tell the difference between HFpEF and PH HFpEF. The patients with PH HFpEF just tend to have a worse prognosis long-term because then they have subsequent RV dysfunction and RV failure. But treating them is the same way. Patients with PAH tend to have a markedly high mean PA pressure and tend to have low cardiac output and a markedly elevated PVR, which is pulmonary vascular resistance. So by putting them all together, their clinical features, you can have a good idea of what type of pH they have just based on those factors. Next slide. So here's an example, step one of an echo. We look at RV size and shape. On the far left, this is pulmonary venous hypertension, or WHO group 2 left side heart disease. You can see the apex on the left ventricle, outlined by red, is apex forming, meaning it's the predominant ventricle that you see in the echocardiogram. Also below that red, there's a big circle, that's the left atrium, that's enlarged in that patient. So definitely left-sided heart disease predominant on that echo. In contrast, the echo on the right with pulmonary arterial hypertension, the right ventricle this time is apex forming. That's delineated by the blue. And the RV is kind of overtaking that left ventricle. And that's a sign of mainly the pathophysiology on the right side of the heart. Next slide. In step two, you kind of look at RV systolic function. On the left, you have pulmonary venous hypertension. Their RV tends to be normal in terms of systolic function. On the right, you can click on that There you go, their TAPC there. That's a marker of right ventricular function. 2.6 centimeters is normal. And this is a pulmonary venous hypertension patient. So once again, the right ventricle is able to battle that left side, and so the right ventricle stays normal. So it's a slow progressive disease. On the right, with PAH, and click it again, the right side starts to balloon and the function starts to drop. This patient's TAPC is only 1.6 centimeters. So markedly reduced, and it's the speed of progression of the PAH. The faster it goes, the right ventricle can't accommodate, and then you have failure caused by that. And the high PVR is the most common cause of the RV dysfunction, which is prevalent in PAH. Next slide. So here on echo, two different ventricles. Both are the left ventricle. On the left, that's pulmonary venous hypertension. Again, very donut shape, very normal in terms of how it contracts. Where in contrast, someone with PAH on the right, the bottom, which is the left ventricle, we call that a D-shaped septum. The right ventricle is imposing its force on that ventricle and is causing the septum to flatten. And that's when you see in the echo reports, we'll say D-shaped septum, and that's because the right ventricle is affecting the left ventricle. So like I said, on the left ventricle, when it's contracting, it's normal, it's round. The right ventricle isn't affecting it. Where in contrast, in pulmonary arterial hypertension, that right ventricle is smushing the left ventricle. It makes the cavity small and cause it to have a D-shaped septum. Next slide. When you look at the transmitral Doppler, this is just a fancy thing we do across the mitral valve, and then to look at the velocities. In the two different diagrams, the one on the far left, we have what is called an increased E to A ratio, and that's what you see in that picture where just the waveform shows that there's problems with relaxation and high filling pressures on the left side. So we know that's left side heart disease. That's grade 2 and 3 diastolic dysfunction. And that could be pseudo-normal, they call it sometimes, or restrictive. Where on the far right, this is a normal pattern or grade 1 diastolic dysfunction, and it's called also impaired early relaxation. And that's just the decreased E to A ratio related to a normal or low LA pressure. When you have that, that means the pathophysiology is normal, tend to be normal on the left side. So the pathophysiology is mainly on the right side, and the one on the right goes more with pulmonary arterial hypertension, where the one on the left goes with more pulmonary venous hypertension. Next slide. So problems with invasive hemodynamics. Hemodynamics are just part of the big picture. There's problems with, we look at their history, their physical exam, their echo, and then the right heart cath, which kind of pieces everything together. The problem with invasive hemodynamics, respiratory variation. So pressures always have to be measured at end expiration. So they take a big breath in, their pressures drop, and at end exhale, that's when you grab your PA pressures, end expiration. When you have an inaccurate pulmonary capillary wedge pressure, we get a direct LV pressure measurement called the LVDP. We go in the artery side and float a pigtail catheter across their aortic valve into their left ventricle. And that way we directly measure their left-sided pressures. And we have to be careful with invasive hemodynamics with an over-reliance on PA pressure estimation. PA pressure is only one part of the picture. What's also very important is their RA pressure, which is the right atrial pressure, their cardiac output, their pulmonary vascular resistance, the PA diastolic pressure to wedge ratios. All those are clinically important as well. So we don't just look at the mean PA pressures to see the severity of the pulmonary hypertension. We look at all those other important variables. Next slide. Here's an example of respiratory variation. You see end expiration, that's the high part, but then they take a big breath in and it goes real low, and then they exhale again. So there's a digital mean that is grabbed, but you don't grab even the digital mean. You take the end expiration. So you take the highest part of that breathing respiration when you record these numbers. Because if you don't, you're doing a disservice to the patient, because these pressures all have to be end expiratory. So you can give a false diagnosis by not recording these in the cath lab appropriately. So that's why it's very important when people have right heart cath, you're able to look at them if you're treating the patient and know what these wave tracings mean. Next slide. So going back to our patient, a right heart cath. So Jane had an RA pressure of 19 and Sarah had an RA pressure of 20. Remember, Jane was the young female, and they both had high PA pressures with a mean of 63 and 64 respectively. But Jane only had an LVDP of 10, so normal left pressure, but Sarah's left pressures were high. They both had a low cardiac index and cardiac output, but Jane's pressures were very high. PVR was 12, and Sarah's PVR was 5.9. So the one on the left is pulmonary arterial hypertension, and the one on the right is pulmonary venous hypertension or left-sided heart disease. Those patients will be markedly treated differently. Jane will be put on pulmonary hypertension meds such as sildenafil or ambrisentan, macitentan, prostacyclins, or all these different pulmonary hypertension meds we use. So she would get those therapies, but Sarah on the right would just get blood pressure control and Lasix to help bring down that LVDP. Hopefully bringing down that pressure will help her right side of her heart. Long term, Sarah's not in a good place either because she has significant pulmonary hypertension with her HFpEF. So both patients have, not the best prognosis having this bad of pH. Next slide. So I'm going to wrap this up by giving you an example of another patient. This is KB. She's a 39-year-old female, referral from pulmonary for evaluation of shortness of breath and dyspnea. Next slide. Her past medical history includes morbid obesity with a BMI of 50, hypertension. She's been tested for sleep apnea and does not have it. She has restrictive lung disease. She has antiphospholipid antibody syndrome, and she has a history of pulmonary embolism ×2 and psoriatic arthritis. Next slide. She had a PE in 2006, and at that time, her INR was kept at 2 to 3 on room air. She, in 2012, about 6 years later, she had a repeat PE in the setting of therapeutic INR. Now her goal INR is 3 to 4, but ever since that PE in 2012, she's been on oxygen for 2 to 3 liters, and she's had progressive shortness of breath, tachycardia regarding beta blocker. She's been treated as asthma, even though her PFTs don't really show that. She gets dizziness with exertion and chest pain, and her mother has antiphospholipid antibody syndrome as well. A lot of people chalk this up to her worsening as her obesity, but remember, she wasn't on oxygen in 2006, and now she's on oxygen, which is new for her. And 2, obesity shouldn't give you oxygen requirements unless there's something wrong with the lungs. So we wanted to look at this further. Next slide. So we did a 6-minute walk test on her. She went 600 feet, which is about 200 plus meters, and she desaturated even on oxygen at 84% on 2 to 3 liters. Her echo shows normal LV and RV function. RV is not well seen. She's unable to get a TR jet and has a normal IVC. Her cardiac MRI was done too that showed a normal right ventricle. Next slide. So what's the next step? No further workup. RV is normal and IVC is normal. We still haven't explained why she's hypoxic, so I think that's not a good answer. Refer to pulmonary for shortness of breath and asthma. Well, her PFTs didn't show asthma, and asthma, unless you're in acute exacerbation, shouldn't make you hypoxic. So I wouldn't do that one either. Start Lasix. Well, we don't know what her volume status is. On exam, it was very tough, so we didn't think that would be the answer. And 2, again, she's a young person that's hypoxic. Just starting Lasix probably is not the right answer. Right heart cath. Well, that sounds like a good plan. That way we can see what her lung pressures are and try to get an answer to what's going on. VQ scan, certainly with recurrent pulmonary embolism, chronic thromboembolic pulmonary hypertension is on your differential. And in some patients don't have pulmonary hypertension. They have what is called CTED, which is chronic thromboembolic disease, without the pulmonary hypertension. So you can have a lot of clot burden without having the pulmonary hypertension right away. Usually years down the road, they eventually develop pulmonary hypertension though. So right heart cath and VQ scan sound like reasonable alternatives. Next slide. So she had a right heart cath. Her mean PA pressure was 28, so mild pulmonary hypertension, not too bad. She had a preserved cardiac output, normal RA pressure, and a normal wedge. So really the hypoxia is still not explained. A mean PA pressure of 28 is barely abnormal. Anything above 20 is abnormal, but that's still in the mild pulmonary hypertension range. And that shouldn't give you marked hypoxia. So that's still not giving us our answer. Next slide. So now what? Continue or workup complete? Well, we still haven't figured out why she's so hypoxic, so I think we should continue. Next slide. So we end up going down a VQ route, and here is an example of the ventilation portion of the scan. You see posterior, and that's looking at the back of the lungs, posterior to anterior, left to right. And as you can see, there's homogeneous uptake of ventilation. So her lung parenchyma per se is okay. So it's not a ventilation issue that she's having for the cause. Now we go to the next slide. The next slide is a perfusion scan. Here it's markedly abnormal. In the different views, just know it looks like a moth-eaten appearance, and that's indicative of ventilation defects. So she's breathing in air, it's getting into the lungs, but the pulmonary beds with capillary flow are not able to exchange oxygen at those levels, and this is where we get perfusion defects. So this is what we call VQ mismatch. Presence of ventilation and absence of perfusion, a VQ mismatch is usually pulmonary embolism. Next slide. So here's a pulmonary angiogram we did. And as you can see, this is her right lung that's selectively engaged. And what you see is there's hyperemia in the right upper lung, and there's no real good blood flow to the right lower lung. And that just shows you that she has chronic pulmonary embolism, chronic thromboembolic disease that's affecting her right lung. So the right side of her upper lung is all good, but the right lower lung is why she's hypoxic. She's not getting blood flow to those right lower lungs. And so she's not able to do oxygen and exchange at that level. So causing VQ mismatch. So we have now an explanation why she has absence, has hypoxia with activity. And remember, she's been anticoagulated for years. So this is not an acute PE. This is more chronic thromboembolic pulmonary hypertension and disease. Next slide. So we referred her for surgery. Typically, when we refer them to surgery, we get an IVC filter placed. And the reason for that is after surgery, we don't want any clots going back up to the lungs. So we temporarily put a filter in place for about 30 days before the surgery and about 30 days after. And then after the 30 days post-surgery, we get the filter out. We then refer to for CTEPH surgery, which is chronic thromboembolic endarterectomy. That was done, and you can see parts of the inside of the pulmonary arteries were removed, and those are the specimens. And then she got markedly better and no longer requires oxygen. So these surgeries can be actually curative of these patients. So definitely when people have chronic thromboembolic disease, we try to get them referred to surgery when they're candidates. Just like with CABG, you don't just take Plavix for the disease, you do bypass surgery. So this is kind of a similar thing. Really, surgery is what's class 1 indication for. Next slide. I think that should be wrapping it up. Thank you very much. I'll be more than happy to answer any questions.
Thank you so much, Dr. Kakalo. That was great. I love the case presentations incorporated as well. Were there any questions, comments, or thoughts based off of that didactic? Feel free to use the chat feature as well. We did get a few more participants join in the middle of your didactic, so maybe we could do a couple of those introductions as well. Lynn, would you like to unmute and introduce yourself for the group?
My name is Linyan. I'm a PhD student in the Clinical and Translational Science program. I muted and closed my video because it's kind of loud here with the equipment in my lab. I'm currently doing a project with Katsu, Dr. Kiddo. He's a pharmacist on the cardiology team working on Entresto and loop diuretics. So that's why I'm joining the project ECHO in cardiac health.
Thank you so much and welcome. We're happy to have you.
Thank you. Yeah.
And Kelly Larson, did you want to introduce yourself for the group as well? You may be muted. She chatted in saying she doesn't have a microphone. No worries at all, but she's the new HF nurse practitioner.
Yeah, Kelly Larson's.
Excellent.
Yeah, Kelly's on the left phone. Kelly Larson, she's our new heart failure nurse practitioner working with us. Glad she's able to join in as well.
That's awesome. Thank you. Any comments? It's okay if there are no questions, but if you have some thoughts, maybe you've seen patients similar to this, the cases that were presented today. All right, well, I don't want to keep you all longer than I have to. It was great to see you all. Thank you so much, Dr. Kakamo, again, for awesome didactic.
No problem.
I'll make sure to include your PowerPoint in the recap email so all of you can have access to it and look through it on your own time as well if you'd like. Just a couple housekeeping announcements. Our next session will be on October 2nd, and Rachel Brocious is providing the didactic on Med Access programs, so keep an eye out for that reminder. I'm sure you all sort of got a bunch of emails from us as well with the updated Zoom link with the password sort of embedded in the link. So Zoom is just updating and requiring us to have passwords now. So if you do have any trouble in the future logging on to any sessions, just shoot me an email and I'll make sure to have the password and updated link sent to you guys. If you don't mind, we do have a quick poll that we like to conduct at the end of our sessions. It's a very brief poll about, I believe, 8 questions. So if I can launch that, you guys can just fill it out. Anytime you finish filling it out, just feel free to log off, and I'll see you guys next time. Thank you so much.